Hello, good evening. Hello, everybody. It's 2 minutes after 6 o'clock New York time. That means it's 2 minutes after midnight in Germany. It's 2 minutes after midnight in Switzerland, where I am. Welcome, everybody, to tonight's session of the Virtual Global Spine Conference. I'm very excited. We have an excellent guest, Professor Melanie Haffner-Luntzer from University Medical Center in Ulm in Germany, where Albert Einstein was born, is today our guest, and she is an international expert about bone regeneration and fracture healing. And she will give us a talk about the most important thing in orthopedic spine surgery, which means what we have to know about fusion and fracture healing. I'm really so happy to have an expert about this field, because we struggle in our clinical practice every week or twice a month, or maybe more often, with pseudoarthrosis, with fractures that are not healing, fusions that don't happen, and maybe we will get some insights how we can do better and what is the future of spinal fusions. What kind of concepts do we have now?
Yeah, thank you. Anyway, I think we can all imagine the clinical problem. I'm no spine surgeon, so I'm not into that topic. But I think we all know that the principles of bone regeneration are similar in the different bones. And this is the topic I want to talk about today. And I hope that at the end you will learn something about bone regeneration and what options do we have to augment regeneration with biologics. And it was just mentioned that, for example, illegal grafting is a technique which seems to be successful, but is not really used. And I just wrote a book chapter about clinical trials in bone regeneration and fracture healing. And indeed, there is not so much evidence for all of the different techniques to accelerate fracture healing. So I do not want to talk today about the classic augmented techniques, but more about experimental research, because I'm a basic researcher, I'm no surgeon. So I of course will start with the clinical problem, but then we'll dive deeply into basic research. So I will start my talk with the fact that bone is we all know that bone is so fascinating. It can adapt to different environmental situations. It can change because of the biomechanical loads, and that is really fascinating. But the most interesting thing about bone is that it has this really high regenerative capacity. So under ideal circumstances, bone has the ability for scarless healing, which is quite unique when you think about other organs. However, what are ideal environments for bone healing? So here you see, of course, the fracture. And you can imagine that this person might not have problems with fracture healing, because this person is really young and sportive. So the chance that this fracture will heal uneventfully is quite high. But there are other situations. When you think about that patient, for example, here you can see a polytraumatized patient suffering from multiple fractures, maybe also chest injury and head injury. And we know from clinical colleagues that these polytraumatized patients are of high risk for delayed fracture healing. And the same is true for this person. So this person is also suffering from multiple injuries, and this person has an enhanced age, which is also a risk factor for delayed fracture healing. So I just want to give you some facts about fractures in Germany. We have about 800,000 fractures yearly in Germany. And of course, fracture incidence is increasing by age because of osteoporosis, the loss of bone mass. So every second person by the age of 65 will have suffered from a fracture during their life. And most of these fractures heal uneventfully, but still 5 to 10% show delayed healing or even non-union formation. And the reasons for that are, of course, the top reason is inadequate fracture fixation, which is a surgical problem. The second most important reason is inadequate blood supply, which is also a surgical, but can also be a biological problem. For example, smokers often have problems with blood supply. Infection is an important topic, but also comorbidities genetic causes, and others. So there are patients where everything is perfect. The environment is perfect. It's a young patient. The surgery was perfect. Fracture fixation is perfect, but the bone will not heal. And the question is why? And this is why further research is needed. And this is basically what I am doing with my group at Ulm University. So I don't think I have to go into detail about the different phases of fracture healing. I just want to emphasize that, of course, everything starts with the fracture itself, the rupture of blood vessels, formation of a hematoma, and inflammation. And many different inflammatory cells are important in that phase. And then, of course, we have the repair phase, where an external fracture callus is formed, where we have bone at the end of the limbs and cartilaginous callus in the middle. And this depends, of course, on biomechanical situation. The higher the strains are, the more cartilage you get, and the lower the strains and the higher oxygen is, the more bone you get. And at the end, there is the remodeling phase, where this external fracture callus is remodeled. And ideally, at the end of all of these different phases, the bone looks completely the same as it was before the fracture. So what are the factors influencing fracture healing, and what are the points we can use to predict if a fracture will heal, and what are the points we can use to accelerate fracture healing? So here you can see some things we and other groups has investigated. So you can see the comorbidities which influencing fracture healing. As I said, smoking, osteoporosis, age, diabetes, and so on. I will go into that later. Hormones are really important. Mechanical factors, of course, and molecular signaling pathways. And I think most of you know BMP, because this is one of the biologics which is approved for fracture healing acceleration. However, for problems, so it is not considered as the ideal biologics to accelerate fracture healing. And today, I want to focus more on the Wnt-beta-catenin signaling in relationship to osteoporosis, age, and also estrogen. So let's start with Wnt-beta-catenin signaling. I'm very sure that most of you have heard about that really important osteoanabolic signaling pathway. In principle, the Wnt ligands bind to the receptors, and then you have a signaling cascade with an activation of osteogenic genes. And this is required for normal bone formation during skeletal formation, but also during fracture healing. And there are different inhibitors of Wnt signaling, and the most important are DICOPF and sclerostin. And there are a lot of studies in mice showing that antibodies inhibiting the inhibitor DICOPF shows an accelerated fracture healing in mice and non-human primates. And there are also studies showing that sclerostin antibody accelerates fracture healing in mice, rats, sheep, and non-human primates. However, just recently, the sclerostin antibody, which is called romosozumab, failed in 2 clinical trials to accelerate fracture healing. So there was a bit of an improvement, but it was not statistically significant. And this was really disappointing when we as basic researchers consider that 20 years of research pointed out that sclerostin is so important, but then when we apply this antibody clinically, it doesn't seem to improve fracture healing. However, now research is going on to focus on more on better patient cohorts, which might be at increased risk for delayed fracture healing, and then maybe the antibody will do something, but we will see. I want to focus about an activation of the Wnt signaling by Wnt ligands. Normally, Wnt ligands are really challenging to give as a therapeutics because they are highly lipidized. But one important molecule and very interesting molecule is Wnt1. Why is Wnt1 so interesting? Because we know from patients that when you have a heterozygous Wnt1 mutation, that causes early onset osteoporosis or osteogenesis imperfecta in humans, as you can see here from these images. And our colleagues from Hamburg showed when you delete Wnt1 in osteoblasts that they also have a severe osteoporosis and increased risk for fractures. And interestingly, Wnt1 is rarely expressed in the adult bone. It's only weakly expressed in osteoblasts and osteocytes. And what the group from Hamburg showed, when you overexpress Wnt1, specifically in osteoblast, you get a really strong bone phenotype, as you can see here. This is the mouse with the Wnt1 overexpression, and you can nicely see the really dense bones, as well as here in the histological section. And we asked the question, can we also use Wnt1 to accelerate fracture healing? So this is our animal model. I will explain it to you because it's a bit complicated. So this animal model is basically for an inducible overexpression of Wnt1, specifically in osteoblasts. And here you can see the gene construct. The take-home message is just when you feed the animals with doxycycline in their chow, there will be no overexpression. But when you remove the doxycycline, then you will get the induction of Wnt1 very rapidly. And what we did, we took mice, and half of them were overreactomized to induce postmenopausal osteoporosis. So you might know that mice do not have a natural menopause, so we have to induce that by removal of the ovaries, and then we get a really nice postmenopausal osteoporosis in this animal. So after 8 weeks, we removed doxycycline from the chow to induce Wnt1 overexpression, and at day 0, we did the fracture surgery. So we are doing an osteotomy at the right femur, stabilized by a semi-rigid external fixator. And then we had a look at the different phases of fracture healing. I don't want to bother you with too much molecular detail, but I want to show you this image. And this was from my first killing of these mice. And you can believe me that I have never seen such a strong effect in my life. And I'm doing that fracture healing research since 12 years now. And this was really obvious something has happened. So on the right side, you can see the fracture colors of a transgenic mouse. And you can see it's all white. And this is because that is all bone. On the left side, this is what a normal mouse bone looks after 21 days, so after 3 weeks of healing. And of course, we quantified that. And what we did was biomechanical testing. Biomechanical testing is the most important parameter to analyze the success of fracture healing in mice. This is something you cannot really do in humans, but this is most important in mice. And here you can see the values for bending stiffness of the fractured femur. And on the left, you can see on the white bars the non-osteoporotic mice, and on the right, on the gray bars, the osteoporotic mice. And you can clearly see when we overexpress Wnt1, we have double or almost triple as high bending stiffness as from the control mice. So there was this Wnt1 overexpression completely projects from the delayed fracture healing, which is obvious in osteoporotic animals. The next step was micro-CT images to quantify the fracture colors and the bone in the fracture colors. And here you can again see what I showed you in the photo, that there is a huge fracture colors with so much bone. And this is also quantifiable, so you can see that here. We can also have a look at histology. And again, in the Wnt1 transgenic mice, you see this increased callus size with a lot of bone, but also a bit of cartilage. So this is safranin O staining, meaning that everything which is stained in red is cartilage and everything which is stained in blue is bone. So you can see we have dramatic effect on bone formation when we overexpress Wnt1, but also a bit on cartilage formation. And so the next step is to find out what is the molecular or cellular reason behind that increased bone formation. And we found that we have, on the one hand, an increased osteoblast number, and on the other side, a decreased osteoclast number, which is like the perfect scenario for increased bone formation and fracture healing. However, this is a genetic mouse model. And of course, the translational relevance of a genetic mouse model with an overexpression of Wnt1 osteoblast is a bit limited. So what we did at the next step was to take a more translational relevant model. And we choose to use a critical size defect model. And in this model, we're having a 1 millimeter gap, which is considered as a critical size defect in young female mice. Here we have a rigid external fixator to stabilize that fracture. And then we applied a collagen gel, you might see it here, which was either loaded with a control protein or the control protein together with Wnt1. And here you can see the reconstruction from the micro-CT images. And this is also day 21 after the fracture, which is a bit early for the critical size defect. So you can see there is no real healing in the control animals, but there is a lot more bone formation in the Wnt1 treated animals. They are not really healed yet, so we would need to wait longer for that, but I think the effect is quite obvious. So we think that Wnt1 might be a potential biologics to improve bone regeneration. And this was just recently published in the Journal of Bone and Mineral Research. And one thing I want to add, because most of you might be spine surgeons, we of course also had a look at the spines of these mice. And here you can see 3D reconstructions from micro-CT images. And red bone is weakly mineralized bone, and yellow is highly mineralized bone. And here you can see these are the transgenic mice, and you can clearly see the effect of the Wnt1 overexpression. So we have a much more denser bone in the vertebral bodies, which is much more mineralized. And we also quantified that, and the effect is really, really strong. And this is not only true for the spine, but also for the intact femur, tibia, and so on. So yeah, Wnt1 might be a potential biologics to improve bone formation in general, and also, for example, for spinal fusion. But we would need to test that. Okay, so that was the first biologics or potential biologics I want to talk about. And the second is about an inhibitor of an inhibitor. So one inhibitor of the Wnt signaling, Midkine, is not so known yet. But we got hands on an antibody inhibiting that, and I want to show you the results of that in the next couple of minutes. So when we applied this Midkine antibody during fracture healing in middle-aged mice, we could clearly see an increase in flexible rigidity because of an activation of Wnt-beta-catenin signaling. But what is Midkine? It's, as I said, it's not really known in the bone field, but it might be an important factor during bone formation and fracture healing. It is known to have an important role in embryogenesis, but its postnatal expression is tightly restricted. It's only expressed in the adult organism in brain, kidney, and bone. It's an angiogenic protein. It's upregulated by hypoxia. It's also a tumor marker for some cancers. It is, as I said, an inhibitor of Wnt-beta-catenin signaling in osteoblasts. And it's also, what is also really important, it's a pro-inflammatory cytokine, which is regulated by estrogen. And that brings me to the fact why we think that Midkine might play a role in fracture healing, especially in postmenopausal osteoporotic women. And you might know that osteoporotic patients in general have a higher risk for non-union development and delayed bone formation during fracture healing. And in the case of postmenopausal osteoporosis, this can be explained by the positive effects of the sex hormone estrogen on bone. You might know that estrogen is accelerating osteoblast differentiation and reducing osteoclast differentiation. And when women lose estrogen after menopause, all of these positive effects are gone, and we have osteoporosis and also delayed fracture healing. So we have a mouse model for that. As I said before, we are removing the ovaries, and then after 4 or 8 weeks, we are combining that with our fracture model. And here you can see that these mice clearly have a delayed fracture healing. And we had a look for Midkine, and we found the Midkine protein expressed in basically all of the different phases during fracture healing. We also had a look at the Midkine in the plasma, so in the circulation, and we found that in the early inflammatory phase, Midkine was significantly higher in OVX mice, so in osteoporotic mice. And interestingly, we also found that in humans, but I will come to that in a second. So what we did now, we took our combined model of ovariectomy and fracture, and we injected these mice with the Midkine antibody. And what you can see here is that the Midkine antibody was able to increase flexible rigidity as well as bone formation in the fracture colors, both in non-osteoporotic, but even better in the osteoporotic mice. So, and the other thing is, I said Midkine is a pro-inflammatory cytokine, and we also know that OVX mice, so postmenopausal mice, have an increased inflammation in the early fracture colors. And this could also be reduced by the Midkine antibody. So basically, inhibition of Midkine prevented all of the negative effects of osteoporosis on fracture healing.
Melanie, may I ask you a question? In the chat box, there was a question: what kind of bone will be modified? Is this cancellous bone, or is this a cortical bone? You've just shown the slide before. It is the fracture healing. I think that there is a differentiation between cancellous bone and cortical bone is not yet there. This is later in the remodeling phase. But can you just give us an information about what kind of bone can be influenced, or is this just the fracture healing process in this phase?
So the first step is always that the cancellous bone is altered, because this is much more metabolically active. You have more osteoblast, which can react to different stimuli, for example, Wnt1 or also the anti-Midkine treatment. But then later on, also cortical bone will react to that. So for example, when I go back and think about the Wnt1 mice, here we had effects on cortical bone as well as on trabecular bone, in the femur and in the spine, and we had this effect on fracture healing. So basically, like all bone was modified by that. But the first effect is always on trabecular bone. And maybe I should also mention in the context of fracture healings that the type of bone is different in mice and humans. So in mice, we have a different organization of the bone structure, so you cannot directly compare it to humans. And this is why, of course, there is always a proof of concept needed that this will also work in humans. And I think this might also be one problem why not all animal data is directly translatable to humans.
Okay, thank you.
Does this answer the question? Yeah.
Yes, thank you.
Wonderful. Yeah, so I think that is exactly the topic now. This was all mouse data I showed you, and we all know that mouse are not humans, and we cannot directly transfer the data. And so we did a small clinical study to analyze the role of Midkine during human osteoporotic fracture healing. Because as I said, Midkine is not known in the bone field so far, and there was no data at all regarding human bone. What we did was we collected serum from fracture and control patients. We collected it directly in the OR, so at the time of surgery, after 14 days and after 42 days. And we analyzed the Midkine. You can see here our patient numbers, they are not really high. So we had long bone fractures, and yeah, it was not so easy to collect the data actually. We did that, of course, in cooperation with the trauma surgery department at Ulm University. But what we first checked was what are the levels of Midkine into circulation when a fracture is happening. And here you can see the controlled patient, so without a fracture. And you can see Midkine is dramatically increasing in the circulation after fracture, and with a peak at day 14. And however, I have to mention, yeah, these are really diverse population of fracture patients, and therefore we have really high standard deviations. But still, it's really interesting. What we also did, we tried to compare, of course, what we also did in mice, like premenopausal and postmenopausal women. The problem was that we hardly had any premenopausal women in our study because we had a look at long bone fractures. So what we did was we compared age-matched males with age-matched females, so basically postmenopausal females. So these were all people above the age of 50. And indeed, we found an increased systemic levels of Midkine in postmenopausal females after fracture, which nicely correlates to our mouse data, right? And of course, it would be wonderful to directly analyze the influence of Midkine and the Midkine antibody on human fracture healing, but this is much too early. We cannot just do that, as you all know, and therefore we took an in vitro system to try to mimic human fracture healing. And what we did was we took human mesenchymal stem cells and we differentiated them in osteogenic differentiation medium towards osteoblast for 10 days with the serum from fracture and control patients. So normally you would use FCS in cell culture, so fetal calf serum, but we did not use that. We just used the serum from our patients. And half of the cells were treated with the Midkine antibody. And we had a look at osteogenic differentiation. And what you can see here is the dashed line are the serum, the cells treated with serum from non-fractured patient. And what you can see in general is that a serum from fractured patients having a negative influence on osteoblast differentiation. And this effect is much more pronounced in the serum from postmenopausal females after fracture. And this is what you can see here on gene expression level with the two markers for osteogenic differentiation. And what you can also see when we treat the cells with the Midkine antibody, we can reverse that negative effect a bit in males, but much more stronger in postmenopausal females. And that was also visible on protein level. So based on that data, we think that there is a possible therapeutic potential for the Midkine antibody to enhance fracture healing and bone formation, especially in postmenopausal women.
Melanie, may I ask you, do you know whether there were similar studies in teriparatide, in analogon from parat hormone, or in denosumab antibody with the rankle gene? Do you know, have there been studies in these fields too before they were translated into clinical practice?
Yeah, absolutely. So many of these therapeutics have been tested in mice before they went into the clinics, like denosumab. I mean, denosumab is the best example because it was basically invented in mice, and then after a long period, it came to the clinics and was really successful. However, the data is limited regarding fracture healing. So that is all very known for, you know, the general effects on osteoporosis and on bone formation, but the data is really limited regarding fracture healing. That is the problem when you think about bone regeneration, especially in long bone fractures. There are hardly any good clinical trials investigating biologics effect. Yeah, but there are good examples where you could translate mouse data into humans.
Okay, thank you.
You're welcome. So that brings me to my first summary. I showed you that Wnt-beta-catenin signaling is a really strong osteoanabolic pathway, and that activators of that, like Wnt1, or blockers of inhibitors, like the Midkine antibody, might be promising biologics to accelerate bone formation. But as I said, more clinical data is clearly needed. I mean, the data in mice look very promising for romosozumab, and now it failed in clinical trials. So let's see what will happen in the future. The last couple of minutes of my talk, I want to dive into one topic which is really important for me, because I have investigated that for quite some years now, and I think that is clearly under-investigated. And that is the influence of psychosocial stress and stress in general on bone and on bone formation and fracture healing. It seems like not so many people are thinking about that, but it seems to have a big influence. So I take the opportunity here to hope to convince some surgeons that this would really have an influence. So you all know chronic psychosocial stress is an increasing burden of our modern society, which is even exaggerated by the pandemic, or was exaggerated, and of course by the war in Europe. It causes many mental pathologies, for example, depression and PTSD, post-traumatic stress disorders. And interestingly, these diseases, especially depression, are linked to an increased risk for osteoporosis and fragility fractures. And we know that psychosocial traumatization and stress promote these mental pathologies. It can promote chronic low-grade inflammation. And we also know from mouse data that it can influence bone. But what does chronic psychosocial stress do with fracture healing? Of course, you could think about big clinical trials, but since psychosocial stress is really a complicated field, it's not so easy, but I will come to some clinical data later. But first, let me show you our experimental model. Our model is a preclinically validated mouse model for chronic psychosocial stress, which is called subordinate colony housing, chronic subordinate colony housing, short CSC. And what we do is we put 4 small male mice in the cage together with a big male mouse. And this is inducing chronic stress to the small mice. Interestingly, that does not work in female mice, and therefore we only have data from male mice at the moment. And our controls are just singly housed. And my cooperation partner in Ulm from the Department of Psychosomatics have shown that the stressed mice and patients with post-traumatic stress disorders share a very similar phenotype. So we combined that stress model with our femur osteotomy model. And I don't want to go too much into detail. I just want to tell you that we found an increased inflammatory response, reduced vascularization, reduced endochondral ossification, and therefore a worse fracture healing outcome. So basically, we found disturbed fracture healing in stressed mice. And I have to mention that the stress was just for 20 days, so it was not too long for the mice. We, of course, investigated in more molecular detail. And what was really interesting is that tyrosine hydroxylase, which is the rate-limiting enzyme in catecholamine synthesis, was really prominent in the fracture callus of stressed mice. And we also found a co-localization of TH and neutrophils in the fracture callus. So it is obvious that catecholamine signaling, which is also a stress response, might somehow interfere with fracture healing. And what we did in a more therapeutical approach, we injected our animals with propranolol directly at the time of surgery. So just once. And indeed, we could completely abolish all of the effects of stress on fracture healing. And since propranolol is an unspecific beta blocker, it seems like the disturbed fracture healing in stressed mice is mediated by beta-adrenoreceptor signaling in the very early inflammatory phase. So we developed the hypothesis that the chronic psychosocial stress is increasing inflammatory bone marrow cells. And these catecholamines then disturb the chondrocyte to osteoblast transdifferentiation, but also bone formation in general, and therefore delaying fracture healing. And we also know it is reducing long bone growth. And this has been shown both in mice and in humans. But this is all mouse data. And again, what is the translational relevance of that data? And when you have a look at the literature, there's only one study showing that there is a decreased functional outcome after forearm fracture in PTSD patients. So we tried to think about what is the influence of psychosocial stress in humans on fracture healing. So we did, again, in cooperation with the trauma surgery department at Ulm University, a small clinical trial. We collected a fracture hematoma from 18 patients with upper ankle fracture. And we choose upper ankle fracture because this is basically the only surgery where you can really get the hematoma because it is just taken away and thrown away. So we could get it and analyzed it. We also did an assessment of the mental and physical health of the patients. We stained the hematoma sections for TH and neutrophils. We analyzed the plasma, and we did a follow-up of our patients 3, 6, 9, and 12 months after surgery. And here I just want to show you some data. We did a correlation analysis between the TH score in the hematoma and the different mental health parameters. And we could see a clearly correlation between TH score in the hematoma with especially depression score, but even higher for stress score, and also for social function and pain, which is really interesting. And when we had a look at the TH staining in the hematoma, it was clearly co-localized with neutrophils. But even more interesting is the follow-up data, because we also get a significant correlation between the TH score in the hematoma at the time of surgery with mobility impairment for 6 months, for 9 months, progress impairment for 9 months, and mobility impairment for 12 months. So that's really interesting. So it seems like stress is doing something with catecholamine synthesis directly in the fracture hematoma, and this might worsen the outcome. This might not be a direct correlation, a direct causation. It can just be a correlation. We don't know that yet. So of course, more clinical data is needed to think about that. But we could clearly show in mice that there is a disturbed fracture healing after psychosocial trauma and stress. It seems like catecholamines and adrenoreceptor signaling is involved, and we have first hints for the translational relevance of that data. So I want to end my talk with saying that bone is so much more than just our skeleton. So it does not only give us support, and broken bones are not just there to heal uneventfully, they are embedded into this whole body system. So we have to consider basically everything. And we also have to consider, for example, the mental status of the patients, but you also know that it is just recently shown that gut microbiome is influencing bone fracture healing as well as brain and so on. So we really have to consider the whole system, and then maybe we will find biologics we can use to accelerate bone formation also in the clinic. Yeah, with that, I'm at the end of my talk. I want to thank my collaboration partners, my whole institute, and here you can see the funding agencies which funded the research of my group in our lab.
Well, thank you very much, Melanie. This was an impressive talk, and I have so many questions. First, I just want to mention that your institute, your laboratory is really huge and well known. It's orthopedic and trauma surgery. You mentioned in your talk the cooperation with the trauma department. But you can test everything, don't you? You have a biomechanic lab, you can use a cyclist, you can use specimens, you can investigate everything, don't you? When I see the collaborations, this is international cooperation. Can you give us a overview how many pathways are there to be investigated? Are there 10 or 20, or does everybody focus on one or two pathways, like you mentioned, the Wnt or the Midkine? Do we have two or three really high interesting pathways, or are there 20 or 30?
So in principle, there are really a lot of pathways, but interestingly, when you think about the new technique, RNA sequencing. This is a technique that is really often used now in research, and basically it's a fishing experiment. So you take the RNA of a callus, for example, and have a look at the different signaling pathways which are regulated. And interestingly, when you have a look at all of the different papers from different groups all over the world, basically there are like 5 pathways which always pop up. This is always Wnt signaling, BMP signaling, YAP-TAZ, it's really important. And one pathway which is also considered as a hot topic at the moment is piezo. So you might know that there was just the Nobel Prize for piezo, not in bone, but in other organs, because it's a mechanosensitive pathway. So basically, I would say there are like maybe 10 pathways, and these might regulate like all of the other pathways, but we cannot date that yet. That's just my guess.
Okay, thank you. And are there possible like vaccinations? Are there messenger RNA experiments going on anywhere in the laboratories? These new techniques we heard about so much in the COVID, in the pandemics?
That's a really interesting question. And indeed, there is a big research going on. Cooperation between Elisabeth Rosado-Ballmajor, who is a professor at orthopedics in Aachen, and Chris Evans. I don't know where he is in the US at the moment. And they are collaborating on that. I think it was Chris Evans. I hope I don't say anything wrong. And they are indeed doing that kind of research in animals, but not only in mice, but also in sheep, for example. And I think they also think about clinical trials. They got a big grant for that. I think it was an NIH grant or something like that. So indeed, something is going on in that regard. And it is like mRNA therapeutics, not really vaccinations, but more mRNA therapeutics in bone healing.
No, thank you. Another question from the chat box. Do you know, not in your mouse model, but in other, do you have good data that some materials we are using in orthopedic surgery are good and not so good? Like, would you, as a molecular medicine expert, go for titanium implants, or do you think that like PEEK or other materials are better? Do you have data for these?
I think it depends a bit on the kind of surgery you think about. In general, of course, you have to consider biocompatibility, but I think what is the most important thing is always like biomechanical competence of the material. So you have to think about what kind of stiffness do you need, what kind of loads are applied to the implant, for example, and then you can decide what is better. I think there is no general answer to that. So I cannot say like titanium is better than what is steel or so, because it really depends on the question. What I can say, if when you think about materials, biomaterials, for example, we did some studies on allograft versus autograft, and autografts are always better than allografts, but I mean, you all know about the problems with autografting. So yeah, it might be the one hand what we think it's better on the biological point of view, but of course you also have to think about the patient situation.
Yeah. And in the beginning of your talk, there were many questions regarding safety, regarding cancer induction. These pathways you have investigated, is there a possibility of inducing cancer? Can they be mutations as well? Because in teriparatide, an analogon of parat hormone, the only indication we have for to use it is history of cancer, could promote perhaps cancer growth.
Yeah, so Wnt signaling is, of course, in principle also involved in cancer growth because Wnt signaling is basically involved in everything. You have to be careful with that. The good thing about Wnt1 is that it seems to be really specific for bone. The group, our cooperation partner from Hamburg, they are also investigating the role of Wnt1 in osteosarcoma, for example, because this is something, of course, you have to consider. I cannot tell you the data yet because I don't know about it, but I know that they are doing some research in that area. Regarding Midkine, the good thing is that Midkine is indeed a tumor marker for colon cancer, for example, and there are, as far as I know, clinical trials ongoing with inhibiting Midkine in these cancer diseases. So inhibiting Midkine also during bone healing might even have a positive effect if you also suffer from cancer and don't know it, for example. But this is just speculation so far. We don't know that yet.
Yeah. Melanie, you often use the word inflammation because it's a physiological phase in fracture healing. What about anti-inflammatory drugs? Because many painkillers we are using when patients have back pain, post-operative fractures. What about anti-inflammatories like NSAIDs, aspirin analogons? Are they good or are they bad from your point of view?
So for the NSAIDs, the answer is really clear. They are bad for fracture healing. So there is a bunch of mouse data for that. And there are even some clinical data. I can remember a talk from David Hack at one of the German trauma society meetings. And he said the evidence is not really good because there is always not really good evidence for anything in fracture healing. But he said that these substances are delaying fracture healing and you should not give them to your patient. And this is also the reason why we are giving our animals tramadol as a painkiller, because it does not interfere with inflammation and also not with fracture healing, as far as we know. And of course, we have to give our animals some painkillers. But this is really an important topic. So inflammation might be bad if it's overwhelming, but it's also needed. So if you block it, you might have severe problems with healing.
Yeah, it's the NSAIDs are the best analgetics for the anesthetics to prevent dependency on opioids. So it's really always a struggle. What kind of painkiller do we use?
Yeah, that's the good thing in mice. You don't have to care about opioids in mice.
Oh, poor mice, poor mice.
Mm-hmm.
Yeah. I have another question because osteoporosis, aging, you now showed us how to reverse in an osteoporotic mice model when you take out the ovary, that you can accelerate fracture healing. But can you give me a good answer? Why is the fracture healing in kids so fast and in people with my age so slow? Because I don't have osteoporosis. What is aging? Can we somehow for fracture healing is there something where we can give anti-aging metabolites to enhance fracture healing?
So I can speculate about that because there is a bunch of data regarding that, but none of that has been tested in humans. So, and from the animal model, we know some stuff. And it's important to know that also in mice, the same is true. So young mice heal much faster than old mice, for example. And that is also true for fish and so on. And it seems like there are a couple of things. One thing is stem cell aging. Stem cells do also age. They lose their differentiation capacity. They lose their anti-inflammatory regulation capacity. You have less stem cells when you age, especially also in bone marrow, and that might be one of the problems. The other problem might be senescent cells. You might know that cells go into senescence if they are basically too old, and they might accumulate in aged bone and also in aged fractured bone. This has been shown in mice. And if you remove the senescent cells, then that can accelerate fracture healing in the aged bone. But I think there are a lot more things to consider. For example, also mechanotransduction. Mechanotransduction is really important for fracture healing, as basically everything is done by biomechanical strains. So it's directed by biomechanical strains. And it seems like mechanotransduction does not really work very well in aged bone. And this could also be one reason why fracture healing speed is declining during aging.
So I should have saved some stem cells from the umbilical cord, didn't I? So for now or for later. Melanie, the last questions I have are regarding the psychosocial stress you mentioned. This is so important because all my patients I see in clinics are unhappy. There's no patient coming in with a big problem and he's happy. And so stress is everywhere, is omnipresent in my population. I have a question to our faculty. I see Nader is there too. Hello, Nader. He is in Chicago, head of neurosurgery. May I ask you, what do you do against psychosocial stress among your patients with a simple fracture? Do you say, okay, come on, it's just a fracture, or do you involve the psychologists in your department?
Fantastic question, and before I answer, chapeau bas to Melanie. This is a fantastic talk, and it always starts at the bench. And you know, we appreciate all of us as a community, spine surgeons, neurosurgeons, and orthopedic surgeons. Appreciate all the work because osteoporosis is a problem, fracture healing is a problem, and you know, we can't overstate how important owning the bone and taking care of bone health. You know, a lot of patients are not really surgical candidates if they have osteoporosis, severe osteoporosis, and you know, then if they're out of the game, they can lead a really unfortunate life. So more and more, answering your question, Alex, more and more I've been appreciating that in clinic, and I'm engaging the primary care physicians. I counsel patients, I take my time to speak with them about it, because I agree it not only affects their you know, healing process, it just affects the overall outcome, you know, overall outcome of our interventions. And if that's not addressed, then the outcomes are inferior. So I've been more cognizant about this. I recognize it. I spend time in clinic counseling them about expectations, optimizing their mental health. You know, it's all about it's a multidisciplinary, multimodal approach to patients healing. You know, the psychosocial, economic factors play into place, the sociodemographics, all that. So it's a holistic approach to getting patients through an operation. Certainly now I learned that, you know, social factors affect specifically bone healing and fracture healing, and you know, that just emphasizes the importance of that and taking that into account.
Yeah.
Do you do that at your practice, Alex? I mean, what's your approach? Let's say you have a, I mean, all I do here, it's like we counsel. Yeah, tell me.
I can tell you, if a patient with a fracture in the geriatric population comes into a hospital, he has got a better environment because we have internal medicine specializing for geriatric patients. What we don't have is a psychological support for 30-year-old, 40-year-old patients. So these patients, these young patients, like younger than me, lot younger than me, they don't get support. It's some kind of scotoma, I think. In the elderly, the grandpa and the grandma gets support. The specialists are there. But in the younger, the psychological support is not good. We have to do better. The holistic approach in the elderly, yes. In the younger, it's a medium, not good. last question from the chat box. Melanie, you've shown in your model that you put a gel into this 1 millimeter fracture line, direct application into the problem zone. The question from the chat box was, because there was a study published recently about BMAC directly into a fractured bone vertebra. Do you see that like a shot into the fracture zone could be a good approach, or do you think maybe a systematical like giving a mouse per oral and the whole body gets the medication, this could be better? Do you think systemic or a local topic treatment is better?
I think when we talk about stem cells, then the local application might always be better, because stem cells, what we think is that they do not differentiate into bone, but they have a regulatory capacity. So they modulate their environment, the inflammation and everything. And they have to be there to do that. So, and for BMAC, I think one recent meta-analysis have shown that if you apply it locally in some type of fractures, that might be really helpful for healing. If you think about like romosozumab or so, that is of course like a systemic treatment. And that is also the good thing about that kind of treatments. But I think for example, this Wnt activators, which is like also BMP2 or BMP7, you have to apply it locally at the fracture site.
Well, thank you very much. It was an impressive talk, Melanie. I didn't expect this part with a psychosocial component in a mouse model. It reminds me of me when I was a neurosurgeon resident in a group of orthopedic surgeons. But it was me with the stress, not the others. It was really impressive, and you have had a brilliant answer to every question. Really impressive. And
thank you so
just
much.
to mention, you are an associate professor in basic research, you told us, but when I see your appearance on the AAOS, you are there where the clinical doctors are. You are exchanging your research projects, your results, and it's so important. And I'm very happy that you took the time at midnight to give us an excellent talk. Thank you very much, Melanie. And I can only recommend follow her on Twitter, on social media. It's always worse to just have a completely different perspective on research on bone remodeling. And Melanie, it was really great having you here as our guest tonight.
Thank you for the invitation.
Thank you very much. And next week we will hear on Twitter in the next days who will be our guest. I say thank you very much wherever you are. Thank you for participating, and einen schönen Abend noch. Gute Nacht nach Ulm. Goodbye, everybody.
Danke.